this area is heavier than the right side. So is it related? It may very well be. An example of a dental hygiene visit, typical child, teenager comes in for a recall exam and a cleaning, and I know those of you that have dental hygiene practices, this is what goes on all day long. We may take some bite wings when indicated. The patient doesn't have any cavities, but what do we see? I see a dental crossbite. I see some recession starting, and this is a 15-year-old. There's premature recession already occurring here on the lower incisor. Oral hygiene's not perfect, but I wouldn't blame the recession in this case on the plaque buildup. This is definitely a heavy contact. And the same thing with the cuspid. If you look on the left side here at this cuspid, the recession is starting. So this is when we want to identify these problems and instill the need. So how are we going to treat this child? Well, really, the best thing for him is to have his teeth lined up so that he is not having occlusal interferences. Part of some of the doctors might prefer to do equilibration, and that's fine too. But we want to be able to identify the problem and then, offer the patients the different treatment modalities. He has generalized 2 to 3 millimeter pockets. He has localized 4 and 5 millimeter pockets. Now, I'm Canadian, so these are Canadian tooth numbers. This is in the second quadrant here on the upper left side, tooth number 2-4 has a 4 or 5 millimeter pocket. 3-2, 3-3, and 3-4 have recession starting. There's crowding, a dental crossbite. He also presents with narrow dental arches, and there's a few other things going on. But we've taken bite wings, and we measure for bite wings, and we take a Panorex to check for his wisdom teeth and to, rule out any gross pathology or any pathology that's existing. But, we measure pockets, of course, and overbite and overjet. These are all things we do all day long. And we can even measure how wide the patient may open. But if there's no concerns or complaints from the patient and they're really not interested in orthodontics, we really need a better tool to instill the need. How are we going to do that? What are we going to do? Oh, the orthodontics to the parent, to them is a cosmetic. So we have to take this situation and instill the need that it's more than cosmetic. Okay? We need to use the gingival recession and the premature recession starting here on the lower incisor as our ammunition to get them to commit to treatment, because the best thing for this child is to have his teeth lined up so that he can, carry on and occlude all day long. Your teeth come together 2,000 times a day when you swallow, so every time your teeth touch, you're going to have, traumatic occlusion occurring. When we chew, we have bolus or food between our teeth, so really the traumatic occlusion isn't necessarily occurring when we're eating. It's usually when we're swallowing and we're bringing our teeth together, or if we're a bruxer. So we can use this information to correct the existing problems so that they commit to the treatment. We need the ammunition to instill the need, and what better way to do it than show them a picture, which I know most of you are doing, but let's show them some TScan data. Our cameras work well, our radiographs work well, but look at the TScan data. This is a still image of a movie. Remember, it was probably an 8-second clench, but basically, and I'll show you in real time in a few minutes how this works, but it doesn't take a rocket scientist to see that there's a lot of red here, and there's tall spikes, that there's obviously a lot more force going on the patient's left side than there is on the patient's right side. And left untreated, this will break down. He's only 15. We want to be able to balance things early on. So this information is what got the patient to commit to treatment. 70% of the forces is on the patient's left, 29% on the patient's right. The new software, which many of you have, will allow us to, with the click of the button, we can actually break down how much percent is per tooth. But for patients, it's good to just show them right and left. You could break it down, and I bet you there would be an awful lot of percentages here in this area of the upper first and second molars region. So parents see this. adults see this. 70-30, it's not balanced. If you ever have any engineer patients, and engineers love this software because it makes sense to them. And this is how we can get the patients to totally commit to the treatment. In this particular case, it was an orthodontic case, but it's not always an orthodontic case. It might be an equilibration case where we can get more forces occurring on the right side. If you want high-tech or low-tech, they all want high-tech. So I've never had anybody say, oh, you know, I'm not interested in the TScan, and please don't do that test on me. Really, patients are very receptive to more information. And what I want you to all understand is that what you're going to do is only going to take you 2 minutes. It's not going to, you're not going to need an extra 15 minutes added on to your hygiene appointment. You're going to use the data very quickly to assess the situation. You're not using it to change someone's occlusion at that moment. You can, you know, really tear apart the TScan data later on at a later date. But what you want to do is you want to use the data as a means to instill the need about a situation. Now, one thing that you need to remember is that if you give the patients too much information, they get overwhelmed and they don't make any buying decision. So therefore, hone in on, you know, 1 or 2 areas and use that information. For instance, here I'd say, well, you've got 70% of the forces on the left and only 30% on the right. So right there, that tells us that your bite is not balanced, and we can see breakdown already starting. It would be really a good idea if you came in for an assessment, further assessment, so that doctor can decide what can be done about the fact that you've got 70-30. Can you still hear me? So he did end up having orthodontic treatment, and you can see the recession's not going to come back, the tissue's not going to grow back, but we can certainly stop it from getting worse. Okay, so this is an example of how the TScan was used to get the parent who thought it was only cosmetic to commit to treatment. He'll have a much nicer smile out of it, obviously, but more importantly is that we're going to prevent the breakdown of soft and hard tissues. We take dental records for many reasons. We take dental records so that a diagnosis can be made. Take records so we can document progression of treatment, obviously for medical legal reasons, and educating the patient is also another reason we take records. Today, the day of paperless practices, using the TScan is even becoming more and more user-friendly because you're also computer literate. Even 3 years ago, training on TScan technology, we used to start our presentations by showing how to minimize and maximize a window, where we don't have to do that anymore because most of you are whizzes at the computer. And this is why the TScan software is Windows-based, very easy to use, and if you can roam around in Windows and use the internet, and you have no trouble understanding the software. But basically, you have to make it part of your records and take the data so that you become very, very good at it. One of the questions that often comes up is, what do we do with these sensors? I mentioned to you in the beginning that the sensors are reusable per patient. Do not use them in between patients because you can't sterilize the sensor. You can sterilize the sensor support, but not the sensor. And if you're using them on the same patient, you can get maybe 20 bites out of it, which really works out to around 30 cents a bite. So it's really not that expensive when you figure out how often you're going to use this sensor on your patients. There's different ways to do it. If you still have charts, you put the TScan sensor in an envelope and just pop it in the patient's treatment chart or in maybe a model storage box. And if you're paperless practice, which most of you probably are or going to be in the near future, there's an accordion file system that I like to use. So you just buy one of these accordion. Now here's our paperless practice using an accordion file, but it's just a small way of tracking your patients. File it alphabetically, put the patient's name on it, the sensor in, and then away it goes. So when they come in, you don't have a chart. You can still go get their sensor. And like I